Welcome everybody to the first episode of Medical Minute. I'm hoping to do these regularly for you all, but today let's start off with a topic that I think a few of you are aware of from a case we had recently, TCA overdose. That's tricyclic antidepressant toxicity. So, first of all, tricyclics get absorbed to the GI tract, and when you overdose on them, you take a lethal dose. Really what they do is they affect your fast sodium channels of your heart. So they blockade those channels, and this causes conduction abnormalities. And what you end up getting is this widened QRS, which you can see in V1. And that's a pretty classic sign of it, as well as some tachycardia. It also has antagonism of the muscarinic, some GABA receptors, H1 receptors. It looks like some anticholinergic effects. But really, that's what you see in these cases. So really, other things you can find is when the patients present, they can have actually some fever, they can have seizure, they can have mental status changes. You're going to find them potentially hypotensive, tachycardic. They'll have dilated pupils from the anticholinergic effects. They'll have a dry mouth. And a couple other things you find with the anticholinergic. You can have absent bowel sounds, urinary retention. But really, those are the classic signs. And then you're just going to look for the medications and look them up and see if they took a TCA. That's really the key. Otherwise, like I said, your QRS generally tends to be greater than 100 milliseconds. So when you have an overdose, my suggestion is always get an EKG. It'll give you a lot of information. But with a TCA overdose, classically you have a widened QRS greater than 100 milliseconds. You can find a deep S wave in leads 1 in AVL, tall R wave and lead AVR. And then, you can have some other findings. That R wave give an RNS ratio of greater than 0.7. As always with treatment, if your ABCs, make sure you get an IV access. If you have to manage the airway. Start with an IV fluid bolus if they're hypotensive. You can always, if it's not responding to the fluids, you can always start levofed. When you start looking at the cardiac toxicity portion of it, if you have a widened QRS, greater than 100 milliseconds, give me a call. We can always push some sodium bicarb. Usually what we'll try to do is about 1 to 2 milliequivalents per kilo, and that usually takes care of things. Usually if they're so far down the hill, as in this case, it's going to take a lot more than that. And really what you're trying to do is just keep them stable long enough before they get to the hospital, because they may need some other mechanisms in place to really stabilize them. There are all sorts of different things if you look at the other types of arrhythmias you can have and what's recommended. Generally, we try to avoid amio in these patients. You tend to stick more to lidocaine. You can also do mag sulfate depending on what the rhythm is. But really, that's what you try to avoid is the amio. You try to avoid other drugs that can actually cause worsening, or your class 1A, class 1C, and 3 antiarrhythmic agents. Otherwise, these patients, as you know in this case, a lot of times they can end up in the ICU if it's a smaller overdose. It is possible you can give some bicarb like I've done in the past to patients. You watch them and then they end up getting discharged. But really, all these patients need to go to the hospital, get evaluated, and ultimately a good number of them will get admitted. If there are any questions, you know where to find me. I hope you enjoy the first Medical Minute and stay safe out there. Bye.